Postgraduate Department of Anatomy, Government Medical College Srinagar, celebrated World Anatomy Day on 14th of October 2023. On this occasion, a series of lectures were delivered by experts from Government Medical College Srinagar. In the following session, let's watch the lecture delivered by Dr. Saleem entitled Anatomical Basis of Ultrasonography. Thank you.
Invite on stage our esteemed chairpersons for the second session. Professor Dr. Samina Farhat, Head of the Department Pharmacology, GMC Srinagar.
Dr. Ashfaqul Hassan, Head of Department Skins Webinar.
Dr. Yasmin Jan, Associate Professor, GMC Srinagar.
Now we would like to invite on stage our esteemed and the most versatile professor of our department, whose expertise extends far beyond the classrooms. Let's invite Professor Dr. Mohammad Saleem Itoo on stage so that Sir enlightens us all about the anatomical basis of ultrasound. So please come on the stage.
Professor Samina Farhat, Dr. Ashfaqul Hassan, Dr. Yasmin, heads of various departments, respected faculty members, my dear students, good afternoon. In this brief session, I am going to talk about anatomical basis of ultrasound. The learning objectives for this session are, I am going to describe briefly the composition of human body. I will give a brief description of ultrasound waves, interaction between tissues of body and ultrasound waves, then use of ultrasound in teaching living anatomy. I will also describe it. Role and scope of ultrasound in clinical practice. Anatomy is mother of all medical subjects. Our body is derived from 3 germ layers and is composed of 4 basic tissues. These tissues have different physical properties like density, elasticity, hardness, and impedance. So they have different conduction velocity for ultrasound waves, and they interact differently with ultrasound waves as these waves pass through these tissues. The lumen of hollow viscera of GIT, in addition to other contents, contains gas. Lumen of viscera like heart contains fluid in the form of blood. Various body cavities like peritoneal, pleural and pericardial cavities are filled with fluid. The ventricles of brain and central canal of spinal cord contain watery fluid in the form of CSF. The density of these fluids also varies. So these fluids have different conduction velocities for sound waves. They also interact differently as sound waves in the form of ultrasound pass through them. As already said, our body is composed of 4 basic tissues. These tissues include epithelial, connective, muscular and nervous tissue. All these tissues are derived from 3 germ layers. If we take section of any part of the body, let it be upper limb. We start from epithelium, which covers it, skin, which is lined by straight fat squamous keratinized epithelium. After reflecting the skin, we come across subcutaneous tissue, which is an example of loose connective tissue. Deeper to that, we have deep fascia, which is an example of dense connective tissue. Then we have muscles attached to the bones, and these muscles are innervated by nerves. So in total, we have the 4 types of tissues. Muscles get attached on the bones, they are innervated by the nerves, and contraction of the muscles makes joints to contract. Now if you take another example of GIT throughout the body has general pattern. Its first layer is lumen, which is lined by the mucosa. Then we have submucosa, in which we found connective tissue there. Then we have the muscular tissue there, and outer muscular tissue is serosa, which is again connective tissue. If we take example of a blood vessel, it is composed of three layers: tunica intima, tunica media, and tunica adventitia. Intima is endothelium, which is connected, which is chelar tissue. In the media, we can have there is muscular tissue, or we can have elastic tissue, and in the adventitia we have nerves and vessels of blood vessels, what we call as vasa vasorum and vasa nervosa. They are also examples of this. So this also present is four basic tissues of the body. Now, brief introduction of ultrasound waves. These are basically the sound waves. They are defined as the sound waves beyond the ordinary limits of hearing. Generation and detection of these ultrasound waves is based on piezoelectric effect. They were noted by Parry and Jacques Curie in 1880. Ultrasound has achieved wide clinical use since 1970. The frequency of ultrasound waves or sound waves, human sensitivity is 20 to 20,000 Hz. The waves with frequency more than that are called ultrasound waves. In diagnostic ultrasound, the waves which are used, they range from 2.5 to 1 to 14 megahertz in frequency. The components of an ultrasound. If we talk about the generation of the ultrasound waves, so we need a transducer which converts one form of energy into another, that is electrical energy, into the signals. A central processing unit like a computer which processes these waves. A display or a screen which displays the image. A keyboard for manipulation. Coupling gel which is used at interface between skin and tissues. Now how does this ultrasound work? The main component of this ultrasound is a transducer, commonly called the probe. This transducer converts electrical signals into the sound waves of different frequencies, and these sound waves whose frequency is greater than 20,000 Hz, we call them as ultrasonic waves. We make these waves to pass through tissues of the body. Some of them are reflected back in the form of echoes. These echoes are fed to the central processing unit of ultrasound, which displays them in the form of an image on the screen. We can manipulate this image by using a keyboard, or we can store it within the ultrasound, or we can print it out and give as ultrasound film to the patient. There are different types of the probes which are used for the different tissues of the body. Nomenclature of these probes is based on shape of the probe. It can be convex, linear, or concave. And we use different types of the probes in different age groups. Now, how do these ultrasound waves interact with the tissues of the body? As already said, our body is composed of four basic tissues. These tissues have different density, elasticity, and impedance. So depending on the impedance of the tissues, which is a product of velocity and density, waves get either absorbed or reflected back or refracted. So by reflection we mean it is the return of incident ultrasound energy as an echo directly back to the transducer and interacting with at a boundary with normal incidence. It occurs at interface with two dissimilar materials. The percentage of beam reflected at tissue interface depends on tissue's acoustic impedance and beam's angle of incidence. So I will try to make it simpler by this way. So one medium we have air, another medium is tissues of the body. A stands for air and B stands for some tissues of the body. And between the two is interface. Now we place a transducer on the surface of the body. It produces an incident beam by converting electrical energy into the sound waves. These waves, after striking the tissue, they get reflected back, and we call it as reflected beam. And this reflected beam, some of the waves pass through the tissue. We call those waves as transmitted beam. Now this reflected beam is projected on the screen in the form of an image. This is the image of the tissue. This is how ultrasound works. But now what is acoustic impedance? It is the characteristic of a material related to elasticity and density, which in turn depends on composition of the body, or it depends on the anatomy of particular organ. It is product of density and velocity of propagation of ultrasound waves through the tissues of the body. It is a measure of resistance to the sound passing through the medium. High density materials give rise to high sound speed and therefore high acoustic impedance. Low density materials have low acoustic impedance. Amount of reflection is determined by the difference in the acoustic impedance of two tissues. Greater the difference, greater the percentage of reflected sound waves. Angle of incidence is angle of reflection of sound beam is equal to the angle of incidence. The angles are drawn relative to the line drawn perpendicular to the surface of interface. Amount of reflection is determined by the angle of incidence. Higher the angle of incidence, less the amount of reflected sound. Now the fraction is the change in the direction of transmitted ultrasound energy that occurs at a boundary interface. Refraction occurs when sound waves meet a tissue interface boundary at an angle other than 90 degrees. The bending of the sound wave by refraction requires a known perpendicular incidence of beam and different propagational speed of two adjacent tissues. So A is one medium, B is tissues of the body. Now these waves, because this acoustic impedance is different, some of them get refracted. Now another way the tissues of the body behave with the ultrasound waves is absorption. It's the only process where sound energy is dissipated in a medium. Here the ultrasound energy is transformed into another form of energy, principally in heat. This form is basis for therapeutic use of ultrasound. Which is used in the treatment of arthritis, and it is also used for the treatment of low back pain. Now what is acoustic window? An acoustic window is the site through which an ultrasound probe makes its scan. Now if we talk about the bones of the skull, at birth there are 6 fontanelles. These fontanelles are in the form of membranes. So normally, these ultrasound waves, they cannot pass through the bones of skull. But if we place the probe over one of these fontanelles, we can detect intracranial hemorrhages and other malformations without going for CT. So because at this age, these fontanelles are in the form of membrane and these ultrasound waves can pass through them, and we can detect intracranial hemorrhage or congenital malformations of the ventricular system. The probe can be turned and or angled in different directions, yielding different view. But all of the views are from the same acoustic window. Now, as anatomists, if we have to do ultrasound of the pancreas, so where from we make these beams to pass? The only possible way of visualizing this ultrasound, this pancreas on ultrasound is we have to make these beams to pass through stomach. Because posterior to the stomach lies lesser sac, and posterior to lesser sac lies pancreas. But during fasting, this, as already said, stomach is filled with gas. So these waves cannot pass through stomach. Then we make the patient to drink water. What happens with drinking of the water? Stomach that is filled with water, and these ultrasound rays can pass through the stomach. So water-filled stomach acts as an acoustic window for visualization of the pancreas. Now we want to do a pelvic ultrasound. In females, we do pelvic ultrasound for uterus and adnexal. Now, these structures, usually they are the pelvic line joining the, there is interlobar fissure which connects gallbladder fossa with the groove for inferior vena cava. It divides the liver into right and left lobes and lies along the Candidi's line connecting gallbladder fossa with inferior vena cava. So we can demonstrate our students on ultrasound that the line connect by taking a section that a line connecting gallbladder fossa with the groove for inferior vena cava, what we call the interlobar fissure, divides liver into right and left functional or physiological lobes. There are certain things which we cannot see on the surface. So what are those things? So blood, if we talk about the venous drainage of the liver, it is drained by right, left and middle hepatic veins. Now we take an ultrasound, we can see these veins. So we have right hepatic vein, left hepatic vein, and in between the two is middle hepatic vein. The thin vein is drained into inferior vena cava. This is here. So they drain into inferior vena cava. Now this pattern, which we can demonstrate to our students, is called inverted umbrella style. So I demarcated here. So three veins, right, left and middle hepatic vein draining into the inferior vena cava. We can see it on the ultrasound. We cannot see these veins on the dissection table. So teaching of ultrasound will help our students in understanding anatomy, those facts which are within the liver, but we cannot demonstrate on the dissection table, but we can demonstrate by taking an ultrasound. And this pattern is called inverted umbrella pattern of hepatic veins. So again, shown there is gallbladder fossa, groove of inferior vena cava, and major interlobar fissure, which divides the liver into right and left anatomical lobes. Now here in this diagram, we can see the division of the portal vein inside the liver into right and left branches of the portal vein. Again, this feature we cannot show our students on the dissection table. We can differentiate between the two, but these walls of the portal vein, they are hyperechogenic. So you can see hyperechogenic walls as compared to the hepatic veins, which are hypoechogenic. So we concentrate it because the wall thickness is more. Again, the composition or anatomy of the tissues comes into play, which helps us to differentiate between walls of the gallbladder, walls of the portal vein and walls of the hepatic vein. So this is the right portal vein, branch from right portal vein, branch from left portal vein, and this one of the hepatic veins. The walls of the portal vein are hyperechogenic. Now everybody can appreciate it, this gallbladder filled with fluid. Now these ultrasound waves can be used for the diagnosis of this gallstones, what we call as polythesis. The basic principle is that these waves, they cannot pass through the stool, so they cast a shadow, what we call as acoustic shadow. If acoustic shadow is there, we say that this is a gallstone. You can differentiate it from the GB polyp, because polyp changes with the posture of the person. But this gallstone changes its position with the posture, but polyp does not change. And this polyp does not give this acoustic shadow. If acoustic shadow is there, we say it is gallstone. So same. So this again the section of the liver. You can see the hyperechogenic shadow is that of the diaphragm. And this shadow, which is hypoechogenic, is that of liver. You will not find the length of liver in anatomy books. When I ask my students during the examination what is length of the liver, they get confused, because the length of the liver is not given in anatomical books, it is given in the books of radiology. We say that because liver being an irregular organ, so we don't have mention of the length of liver in anatomic books. So we find it is mentioned in the books on sonography. So normal length of liver is 16 centimeters. We take it from diaphragm to lower pole of the kidney by placing a probe in the mid-clavicular or mid-axillary line. As shown in this diagram, we take the length from in the mid-axillary or mid-clavicular line from diaphragm to the lower pole of the kidney. Normally this lower pole, so this is again a section of the liver where we can see the hepatorenal pouch of the Morrison. So we have this is the right kidney, longitudinal section, this is the right lobe of the liver. So between the undersurface of the right lobe of the liver and anterior surface of the right kidney lies the hepatorenal pouch of Morrison. Since both inferior surface of the liver is covered by peritoneum, and same is true for the anterior surface of the kidney, it gives a glistening appearance. So this is the Morrison's pouch. It's basically a potential space. So going to the Morrison's pouch, it is also called the hepatorenal pouch of Morrison. It is one of the suffragate spaces. It is bounded superiorly by the right lobe of the liver, posteriorly by the anterior surface of the right kidney. In between the two lies the potential space, what we call the hepatorenal pouch of Morrison. So this Morrison's pouch is a potential space. So normally it does not contain any fluid, as shown in the sonography section. In the kidney we can see both cortex and medulla. Density of the cortex and medulla varies. So this medulla is hyperechogenic as compared to the cortex. So this is the left lobe of the liver, this right kidney, this upper pole and lower pole of the right kidney. We can take measurement of the right kidney by taking pole to pole length on ultrasonography. It is 9 to 12 centimeters. Now, as already said, this Morrison's pouch or hepatorenal pouch, the potential space, under normal conditions it does not contain any fluid. But under pathological conditions or in case of the trauma, fluid enters in the hepatorenal pouch of Morrison. We can pick up this fluid by using an ultrasound. So on the right side you will find A is the right lobe of liver, B is right kidney, and this yellow line is the Morrison's pouch. Now in the B section we will find between liver and kidney, in the Morrison's pouch, there is accumulation of this fluid, and this accumulation of the fluid, accumulated fluid gives hypoechogenic shadow. Now, basically kidney consists of two parts, collecting part and secretory part. Obstruction due to any reason, the collecting part due to dilatation, what we call as hydronephrosis. There are different grades of hydronephrosis. What do we see? Now we see the fluid collection within the collecting part of the kidney, which compresses on the renal cortex, leading to renal atrophy and derailment of renal functions. Now, ultrasound can be also used to diagnose what we call as polycystic kidney, where we find fluid-filled cystic cavities in kidney. Now, this is an ultrasound of the pelvis. So we take a section of pelvis, we see from anterior to the posterior in females, anteriorly lies bladder, posteriorly lies uterus. By taking advantage of this acoustic window which is formed by the fluid filled in urinary bladder, we can visualize the posterior inclination uterus with its parts, that is fundus body, and so we can even see the cervix. So in this diagram, we can see the branches of abdominal aorta, both paired and unpaired. At times, there is aneurysm of abdominal aorta, that is dilatation of abdominal aorta. Normal dimensions of 3 transverse and wall-to-wall diameter. If it is greater than 3 centimeters, we say it is an aneurysm. We can pick this aneurysm by taking a transverse section of the abdominal aorta and then measuring it is wall-to-wall diameter. So the commonest site for abdominal aneurysm is below the origin of the radial arteries, and outer to outer wall diameter greater than 3 centimeters suggests an aneurysm. We can also see, using ultrasound, we can see other branches of the abdominal aorta. So in this picture, this abdominal aorta, then abdominal aorta gives celiac trunk divides into splenic artery and hepatic arteries. And this pattern, we call it as Siegel sign. This is the longitudinal section of the abdominal aorta, where we can see the superior mesenteric and inferior mesenteric arteries originating from it using ultrasound. The abdominal aorta divides at the level of L4 into the common and into right and left iliac arteries. By taking a transverse section, we can see the division of the abdominal aorta into right and left common iliac arteries. So in case of pancreas, we said that pancreas wraps around splenic vein, and for visualization of the pancreas, we take the superior mesenteric vessels, that is superior mesenteric artery and vein. They act as guides. So this is a superior mesenteric artery whose palpation and the pulsations can be seen on the ultrasound, and we can take a section. We can also see the superior mesenteric vein using ultrasound. So in this section you can see superior mesenteric artery, splenic vein draining into the portal vein, and we can see the abdominal aorta and inferior vena cava. Ultrasound is also used for measurement of splenic dimensions. So in case of spleen, we take pole length of the spleen, and we can see also various relationships of the spleen. So by taking pole length of the spleen, we say that, so we take from pole length of the spleen up to 13 centimeters, we say it is normal, and greater than that, we say it is splenomegaly. So the patient, in this diagram, you can see a patient present in the catheter with the retention of the urine. The catheter is passed and the urine is drained. On taking ultrasound of this patient, what do we see? There is something inside the urinary bladder. This is basically the enlarged median lobe of prostate, what we call as uvula zygote. On postmortem of this patient, we can see in the dissection hall enlarged lobe of the prostate, middle lobe of the prostate within the urinary bladder. So it is uvula zygote. So how did this Postgraduate Department of Anatomy? Our department is one of the few departments in the country which have this USG lab. Thanks to Dr. Shahi, who brought 2 ultrasound machines for our lab. So this lab was established in 2011. She managed training of our faculty from the Department of Radiodiagnosis. She included USG teaching in our curriculum. We are teaching students in small batch, it is going on. Then we evaluate students by keeping 2 to 3 sections or spots in the examination. One of our postgraduates was given a research project based on ultrasound. Other 2 postgraduates. How do we evaluate our students? So we keep 1 or 2 spots in the examination. For example, this one of the spots which I keep in the examination, identify B, and what is the length of B? So A is right lobe of liver, B is right kidney, and the length is 9 to 12 centimeters. So part number 2. So identify B. Again, A is right lobe of liver, B is right kidney, and C is moisture heart. I want to summarize my lecture as human body is composed of 4 basic tissues. The physical properties of these tissues, like density, elasticity, and impedance, vary depending upon their composition. So the tissues interact differently with ultrasonic waves. Thus, the images of the tissues produced by ultrasound are dependent on composition or anatomy of a tissue or an organ. Dissection of human body is performed with the help of a knife and blade. Appreciating these structures with hands creates a permanent impression in brain. In ultrasonography, knife is replaced by transducer and images are displayed on screen. It lacks the phenotype of dissection and its impressions created in the brain are not everlasting. But combination of the 2 is always better for understanding with anatomy forming basis of ultrasonography. Thank you.
Dr. Saleem, thank you so much for your lecture.